Good afternoon, everyone. PCOE MCH Kolkata welcomes all the participants for today's RDLS session. Today's topic is post-exposure prophylaxis for HIV, that is PEP, and the speaker is Dr. Prasenjit Saha. Dr. Prasenjit Saha, sir, is presently working as a senior medical officer with the ART Center at Medical College and Hospital, Kolkata. He is also a resource person for healthcare professionals in various trainings and workshops in different forums. He has been working with various organizations in the field of community health, STD and HIV, sexual health, and drug use disorder. He has been empaneled at Saksham Expert Master Trainer for Global Fund Round 7 by the University of Kolkata. We welcome you, sir, for today's session and request you to start the session.
Ma'am, give me 5 minutes. Actually,
Yes, sir.
sir,
No problem. No
yeah,
problem. No problem.
yes.
Kiran, sir, can we stop the recording till then?
Hello.
Sir, you can continue, please.
Okay. Good afternoon, everybody. All of you are welcome to this RDLS session. Today's topic is post-exposure prophylaxis for HIV, PEP. What are the objectives of today's RDLS? By the end of this session, all the participants will be able to understand the risk of HIV transmission through occupational exposure, first aid that is given after occupational exposure, counseling for persons reporting with occupational exposure, prescription of PEP drugs and follow-up procedures, prevention of occupational exposures, documentation of occupational exposures reported to the ARTC center. Post-exposure prophylaxis. This actually is an umbrella term. It includes everything from starting from first aid to the PEP given, all the investigations, counseling. Everything is contained in this umbrella term known as post-exposure prophylaxis. And what exactly is PEP? It refers to the comprehensive management, that is total management, instituted to minimize the risk of HIV infection or Hep B infection or HIV following potential exposure to blood-borne pathogens. PEP is the standard protocol for preventing chances of getting HIV infection when a healthcare provider is exposed to a source patient known to be a potentially HIV infected. That is occupational exposure. NACO guidelines describe the risk of infection, the preventive measures, and the steps to be followed to deal with accidental occupational exposure to HIV and other blood-borne pathogens. The post-exposure management protocols is an important element of workplace safety and prevention. What are the types of exposure? Exposure which may place a healthcare provider at risk of bloodborne infection is defined as a percutaneous injury with a needle stick or any other sharp, contact with mucous membranes of the eye, mouth, or nose, contact with non-intact skin, chapped skin or dermatitis or abraded skin, prolonged contact of intact skin with blood or other potentially infectious body fluids. These all, when exposed during the work procedures, during doing job work, is known as occupational exposure. Another exposure which is apart from this occupational exposure is known as non-occupational exposure or NPEP. So what is occupational exposure? Let me reiterate. Exposure to potential blood-borne infection, that is HIV, Hep B, Hep C, etc., during performance of job duties. And non-occupational exposure includes or refers to exposure to potential blood-borne infection, HIV, Hep B, Hep C, etc., outside of the workplace setting like unsafe sex, sexual assault, etc. Who are at the occupational risk of blood-borne infection? Everybody basically who are working at the hospital or medical institutions, nursing staff and students, emergency care providers, labor and delivery room personnel, surgeons, operation theatre staff, lab technicians, paramedical staff, physicians, interns, medical students, dentists, healthcare facility cleaning staff, mortuary staff, and clinical waste handler. Basically, whoever is working in the healthcare institute, everybody is at risk of getting an exposure through needle sharp or through a braided skin, etc. Now we have a case one, and I want all of you to go through this case and put your answers in the chat box. Write A if you think A is the right answer, B if you think B is the correct answer. Basically, this not you have all the answers are correct or wrong for that matter, but whenever you write something, give your reasons for choosing that answer or that option. A, healthcare worker during disposal of sharps from a obs gynae theatre has a prick on his finger after a HIV positive delivery. And B is an internist had a splash of pleural fluid on his face from an HIV positive individual. Did all of you get it? Please type A or type B and give reasons for choosing your option. I'll give you 1 minute or 30 seconds. Sweta ma'am?
Yes, sir. So we are getting responses in the chat box. People are putting A. The reason given is direct inoculation.
Okay. Wonderful. Good answer. Absolutely. It is direct inoculation. So chances are more. It is also very important. There's a splash of pleural fluid on the face. If it's the eye, the chances are there. But definitely, this is a case of direct inoculation from the OG theater. So good job. Next slide, please. So who is at risk? So we have got the answers. Next slide, please. So let's look at the potentially infectious material from the body. They can be divided into two halves. That is, exposure to body fluids considered at risk. Potential infectious material, they are blood, semen, vaginal secretion, cerebrospinal fluid, synovial, pleural, peritoneal fluid, pericardial amniotic fluid as well, other body fluids contaminated with visible blood. These are all potentially at risk body fluids. And exposure to body fluids which are considered not at risk, potentially not infectious, unless these visible fluids are visibly contaminated with blood. They include tears, sweat, urine and feces, saliva, sputum, and vomitus. So if they're contaminated with visible blood, they become potentially infectious as well. So we have to keep that in mind. Next slide, please. HIV transmission risk by different routes. We know maximum transmission, most effective transmission is through blood transfusion. That is more than 98%. It is the most effective route of transmission. From mother to child without any intervention is 20 to 40%. And sexual intercourse is 0.1 to 1%. And for injecting drug users for PWID, it is around 0.67%. But just because we are talking about PEP, we need to stick to needle stick exposure, that is around 0.3%. And splash to the eyes, oronasal membranes, and any other cut injuries or abraded skin, chances are 0.09%. So if you look at the comparative risk of needle stick injury for Hep B and Hep C as well, they would tell you the risk factor for Hep B is 9 to 30% for needle stick, which is 0.3% for HIV, and for HCV is 1 to 1.8%. This is a very easy formula to remember. That is how I remember, and many of us remember that way. For hepatitis B, it is 30. For hepatitis C, it is 3.0. For HIV, it's 0.3. It's a multiple of 30. So hepatitis B is 30, HCV is 3.0, and HIV is 0.3. Next slide, please. And the risk depends on type of body fluid as well. We have just learned a route of contact or exposure. So they look at the picture. This the cartoon is wonderful. The person is thinking, the young boy is thinking, which has more risk? What are the risk factors that would sort of increase my chances of getting the infection? So we'll know, we'll clarify. Next slide, please. This is the case 2. A medical officer presents to the emergency care for evaluation of needle stick injury that occurred 2 days prior while inserting an intravenous line to a HIV positive patient. The medical officer did not turn up at the ART center or the person in charge of ART center, but he came or she came after 2 days. So next slide. Right. Can we start PEP in this situation? The person is, the doctor is 48 hours less, is more than 48 hours. Should we? Are we supposed to? Would it be efficacious? I would request all my fellow friends to write the answers in the chat box. I'll give you 30 seconds, please. Sweta ma'am, are they writing? Please, the doctor has reported to the active center after 2 days. In this scenario, should we be prescribing PEP? Should we advise him to take PEP? Or we should say you are not supposed to take PEP at all? What should we be doing? I need your inputs, friends. Sweta ma'am, am I audible?
Yes, sir, you are audible.
Okay. Kiran sir?
Yes, yes. People are typing.
Typing. Okay. Sir.
Yes, yes, is
Yes, sir.
typing.
Yes, absolutely. We should start PEP in this situation as well. So, next slide, please. Things to know before starting PEP. What is the risk for contracting HIV? Are there factors that might affect this risk? Of course, there are a lot of factors that would augment or modify. How effective is PEP? Is it too late to start PEP? What are the drawbacks of starting PEP? Which regimen should be considered? What follow-up should be arranged? Next slide, please. Average risk of acquiring HIV, Hep B, Hep C after occupational exposure, we have just explained. So types of exposure is percutaneous injury. For HIV is 0.3%, for Hep B is 9 to 30%, for HCV is 1 to 1.8%. For mucous membrane exposure on chapped skin, abraded skin, and the HIV infection risk factor is around 0.09%. Next slide, please. Other likely risk factors are amount of viral load. If the viral load in the source patient is high, chances of getting HIV, contracting HIV to the exposed person is higher, naturally so. If the glove, if a person, the healthcare provider uses glove, there's more than 50% decrease in volume of blood transmitted. Hence, chances of contracting HIV would be lessened, definitely. Hollow bore has lot of blood than a solid bore, and large diameter needles weakly associated with increased risk factor, surely, and drying conditions. There's a tenfold drop in infectivity every 9 hours. This we can find out in lab setup. Basically, if the blood drop or the fluid dries up, chances of HIV infection would come down. What are the steps of management of the exposed person after exposure to an HIV sort of HIV exposure? Step 1, management exposure site. That is the first step. Step 2, establish eligibility for PEP. Should we be giving or not? Counseling for PEP is very, very important. It is one of the important cornerstone for the person to start and complete his PEP drugs. Step 4 is assessing need for PEP and prescribing PEP. Step 5 is lab evaluation. Step 6 is follow-up. Next slide. This is the first step. So step 1, management of exposure, first step. If the skin is pierced by a needle stick or sharp instrument, what is the natural instinct we do? Immediately we take our fingers or hand and put it inside our mouth to stop the bleeding. But do not put it inside the mouth in reflex action. That should be stopped immediately. Immediately wash the wound and surrounding skin with water and soap and rinse. Why are we supposed to do that? Because we know that the HIV is surrounded by a glycoprotein membrane, and soap is alkaline. So this alkaline milieu would wash away or destroy the HIV virus. So less chances of HIV infection getting into the body. Excuse me. Do not rub that area, that would traumatize. Do not use antiseptics or skin washes. Do not use bleach, chlorine, or alcohol. That would lead to more trauma to that area. More trauma means more CD4 cells, more CD4 cells, more T lymphocytes, and the HIV virus, if it is around, chances of lodging into one of the cells would be higher. So that should be avoided. It is water and soap and water only. Consult the designated physician of the healthcare unit for management of exposure immediately. Next slide, please. Management of exposure. If eye is involved, irrigate the exposed eye immediately with water or normal saline. Do not put soap and water. Tilt the head back and ask a colleague to gently pour water or normal saline over the eyes. If the contact lenses are there, let the contact lenses be there for some while irrigating, as they form a barrier over the eyes, and that would help in protecting it. Remove the contact lenses, clean them in normal manner, the way one does. This will make them safer to use it again. Do not use soap and disinfectant on the eye. Consult the designated physician, as I have told you before. If the mouth is involved, spit fluid out immediately. Rinse mouth thoroughly using water or saline water. Spit again. Repeat this process several times. That would wash away the virus. Do not use soap or disinfectant in the mouth. Consult the designated physician. Next slide, please. Establish the eligibility for PEP. Should I be giving PEP? For which situation we should be knowing it? We should have an idea. The decision on the need of PEP for HIV following an occupational exposure in healthcare provider will depend on the exposure, the source person HIV status, and the extent of the disease or the severity of the disease if the source has been confirmed positive. It is decided on exposure code and source code. For exposure code, we always have this, whether the material is blood or bloody fluid or other potentially infected material or OPIN or instrument contaminated with one of these substances. If the answer is no, it is not potentially infectious, PEP is definitely not required. If the answer is yes, we go to the next step, that is what type of exposure occurred. Mucous membrane, skin or integrity compromised? If it is yes, amount of fluid that has gone into the body, that is the volume of the infectious material. Small volume, few drops, short duration, we call them exposure code 1. If the case is with larger volume, major splash, long duration, exposure code 2. And if it is on an intact skin, definitely we know HIV cannot penetrate intact skin. If there are no abraded skin, there's no chapped skin, no mucous membrane, definitely no PEP is required, definitely. And if it is a case of percutaneous exposure through needle stick injury or sharps, so we have to gauge, we have to find out the severity of the exposure. If it is less severe, solid needle, superficial scratch with a sharp, so we call this exposure code 2. If the exposure is more severe, hollow bone needle, deep injury, We call it exposure code 3. So we see there are 3 layers of exposure code. Exposure code 1, exposure code 2, and exposure code 3. Next, please. Categories of exposure. On the left side, we have the exposure, mild, moderate, and severe. On the right side is definition and example. Mild exposure is defined as exposure to mucous membrane, non-intact skin with small volumes, contact with the eyes or mucous membranes, or subcutaneous injection following small bore needles. Moderate exposure includes exposure to mucous membrane with large volumes or percutaneous superficial exposure with a solid needle. For example, a superficial cut or needle stick injury penetrating through a glove. What is the severe exposure? They are percutaneous exposure with a large volume, an accident with high caliber needle visibly contaminated with blood, deep wound, or an accident with material that has been previously used intravenously or intra-arterially. There's a footnote which says the wearing of gloves is one of the important standard workplace precautions. Blood glove punctures do happen. In case of accidental exposure to blood with materials such as sharps or needles, dried contaminated blood, the transmission risk remains for a week for HIV. Risk remains most significant for Hep B and Hep C as they survive longer than HIV outside the body. First, we spoke about exposure code. Now we come to source code. It's about the severity or the advancement of the HIV disease in the source. Source of exposure, HIV status. So it is divided into 3 major categories. HIV negative. If the source person turns out to be HIV negative, definitely we do not need to give PEP. If the person is HIV positive and the low titer exposure asymptomatic, high CD4 count, viral load is suppressed, then we call that severity is less and the chances of infection is less. So we call that person, the HIV source code is source code 1. And for high titer exposure, advanced disease, low CD4 count, unsuppressed high viral load count, definitely this is a case of advanced HIV disease. The source code is 2. For whom HIV status unknown or the source person refuses to go for the HIV status, you cannot force a source person to go for HIV status. It is confidential as well as voluntary. Remember that. You cannot force somebody like that. So if you do not have that unknown, it would depend on the prevalence, epidemiological status of that area. So we'll talk about it. Next slide, please. Recommendations for PEP for healthcare personnel based on exposure and HIV source code. On the first column is the exposure code, second column is the source code, and recommendation for code for PEP. Exposure code 1, source code is 1. So total is 2. PEP, according to NACO guideline, PEP is not warranted. Exposure code 1, source code 2, recommended for PEP. Source code 1, exposure code 2, source code 1, PEP recommended. Exposure and source code both 2 plus 2, 4, it's recommended. Exposure code is 3 and source code is either 1 or 2. PEP is recommended definitely. Exposure code is 2 or 3. Source code is unknown. Then we have to consider PEP if HIV prevalence is high in given population in the region and risk of categorization. When I talk about prevalence in that area, we not only talk about of that area, we talk about if the exposure has happened in the ART center. Definitely you have HIV patients only. So it depends in which part of the health institute the person has been exposed and the HIV prevalence in that area. At the same time, which is important is the risk factor. risky behavior of the source patient. Everything has to be kept in mind. And PEP is recommended for total 28 days. Here I want to tell you, let's go back. I want to tell you that whatever the source code might be, usually for all practical purposes, we always recommend PEP. Why? Because some people might want PEP drugs in spite of telling them that there's chances of risk is very, very minimal or negligible. For example, when the exposure code or source code is 1+1, it is not warranted. But the patient would ask, the client or the healthcare provider would be after you. He would tell you there's a deep cut injury, there's a cut injury in the nail bed, and so on and so forth. Naturally, we understand the anxiety level the person is going through. So these are known as worried well. So in such cases, we still have to go for PEP. So this is a practical experience which I have gathered since working since so many years in this field. Thank you. Next slide, please. Step 3, counseling for PEP. The exposed person should receive appropriate information about what PEP is. This is very important, and the risks and benefits of PEP for an informed consent. We cannot force anybody to take PEP drugs, but he should or she should understand, then sign the form. It should be made clear that PEP is not mandatory, but needs to be taken for his or her own health need. The patient should, or the HCP should know the details of window period, baseline tests, drugs that are used, safety, efficacy, adverse drug reactions, adherence issues, preventions, etc. Counsel on safe sexual practice are very important till both baseline and 3 months HIV tests are found to be negative. Till the person, the healthcare provider is found negative in both the cases, he should go for preventive sexual practices or safer sexual practices. Receive counseling women regarding use of PEP during pregnancy and breastfeeding. Psychosocial support is very, very important. I told you it's one of the cornerstone. Many people will feel anxious, and rightfully so, or depressed after the exposure. Some may require further specialized psychosocial support. As such cases, we refer the patient to a psychiatrist for the well-being of the patient or the healthcare providers. Be informed about the risks and measures that can be taken to help relieve part of the anxiety. In case exposed person opts out for PEP, even after intensive counseling, he should be advised for testing of HIV, HCV, Hep B at baseline 6 weeks, 12 weeks, and 6 months from date of exposure. And remember, documentation on record and reporting is very, very essential. Everything has to be documented in SOCH as well as in your registers. Next, please. Evaluation of occupational exposure sources. Known sources. Test known sources for Hep B, anti-HCV, and HIV antibody. Direct virus assays for routine screening of sources patients are not recommended by NACO. You don't need to. Considering use of HIV antibody test or rapid test has to be done at the ICTC. If the source person is not infected with a blood-borne pathogen, baseline testing or further follow is not necessary at all, which I told you. Go back. Let's go back. Go back. Go back, please. Go back. Go back. So you see, if the person is HIV negative, PEP not required at all. Next slide. Not required. So, and another thing that is very important, we have seen at times, do not discard needles. The discarded needle and bloodborne for pathogens should not be tested. Some people are over enthusiastic. They bring the needles and sharps with visible blood sort of sticking to them for HIV testing. Don't do that. We do not test blood from discarded needles or sharps. We sort of stop that. We don't do it. For unknown sources, Evaluate the likelihood of exposure to a source at high risk of infection. Consider likelihood of blood-borne pathogen infection among patients in the exposure settings. Next slide, please. When should PEP be started? Very pertinent question. Each one of the HIV physicians should know this. Next slide, please. So when should PEP be started? So look at this graph. Look at this graph. The this x-axis represents time, and the y-axis represents benefits of PEP. With time, as you delay PEP, the efficacy, the efficiency of PEP does declines. It declines. So efficiency of PEP thought to wane with time. And what point is time no longer worth it? Next slide, please. Let's look at the path of HIV transmission in the host. Day 0. This is a very common slide. All of the HIV physicians must have gone through this. At 0 day, exposure to HIV at mucosal surface. This is an animal model test. Sex during sex. Day 0 to 2 days, virus collected by dendritic cells carried to the lymph node. Day 4 to 11 days, HIV replicates in the CD4 cell, remains into the in the blood. So there is viremia. Up from this point, is very difficult to stop HIV infection in the person. So it should be within these 2 days, 0 to 2 to 3 days. From day 11 once, virus spread to other organs as well. Next, we cannot stop the HIV infection from starting. So timing of PEP, what is the evidence? This is an animal model study, which says that substantially less effective beyond 24 to 36 hours. Case control study tells us most subjects in each group received PEP within 4 hours. Analysis of PEP failures does not suggest a clear cutoff. We cannot say which is the correct time. It does not tell us the correct or clear cutoff sign. Next slide. We have to give anyway. Next slide, please. Next slide. Duration of PEP. In animal model study, 28 days more effective than 10 days or 3 days of PEP. 4 weeks, 28 days used in case control study and recommended by CDC guidelines, and NACO follows that guideline. Next slide, please. Key consideration while prescribing PEP. PEP should be started preferably within 72 hours after exposure. The moment there's an exposure, the best is as soon as possible. It is always as soon as possible. Stop that work. Do not panic. Hand over to your work, what you have been doing, to your colleague. Call out for help. Please do not panic. That would be detrimental for your seeking behavior, but should be done immediately and definitely within 72 hours after exposure. The HCP presents after 72 hours exposure. PEP can still be offered after counseling about its effectiveness. As now we have learned that even after 72 hours we can give, but the efficacy wanes with time. It comes down with time. So that has to be borne in mind. PEP should be made available in the emergency department. It should be kept in the labor room, intensive care units, OTs, and if you want to keep in other units also, you can definitely do it. It is always for the benefit of the healthcare providers. Please do it. And remember, you just keep the PEP drugs and forget about it. Definitely not. And the staff nurse should be involved. The medical officer in charge should be involved, and you should inform the nursing staff at that various departments and tell them if there's they have run out of PEP drugs. Before they run out, they should come to the ARTC center for replenishing the pill box, and at the same time, if it's nearing expired, just to exchange the pills and get new pills. So, and the near expired pills are not wasted as well. The exposed person should go to the designated clinical doctor at the earliest for a complete risk assessment, HIV counseling, testing, and PEP drugs if needed. All hospital staff members must know whom to report for PEP and where PEP drug is available. Just keeping PEP drug is not enough. There should be a pamphlet, so there should be sensitization program, or you can put sort of kind of posters in strategic places where people know where it is kept. Next slide, please. Key consideration: PEP should be started as soon as possible, within 2 hours, preferably within 72 hours of exposure, based on eligibility assessment. You still can start PEP after 72 hours, but the exposure or effectivity of PEP drugs goes down. As I've just told you, and proper counselings are very, very important. Please, counselors should be involved. It is not for the doctors to counsel only. Counsel with their counseling skills should be greatly involved, actively involved. Prophylaxis needs to be continued for total 4 weeks. There was a question, somebody asked me, sir, I have taken 4 weeks of medicine. I had an exposure in between. Would this do? Definitely not, because the moment you have an exposure in between, so there's a need for PEP drugs after assessment, you have to start from that day becomes day 1 again, and you have to continue for another 4 weeks as well. I hope I'm clear. Counseling to be done also by prescribing doctor and the counselors as well. In cases of sexual assault, PEP should be given to the exposed person as a part of overall package of post-sexual assault care, and all pediatric sexual assault cases need to be notified to the concerned authorities. This is legal issues. Please inform your nodal officer and all those concerned person, because if it's a children, there's a POXO Act, we know. So everything should be kept in proper place, and documentation is a must. Next slide, please. What are the recommended PEP regimens? If the exposed person is more than 10 years and above 30 kg of body weight, preferred regimen is tenofovir 300 mg, lamivudine 300 mg plus dolutegravir, 1 tablet once daily. An alternative regimen, if the preferred drug is contraindicated or not available, whatever might be the reason, we might go for tenofovir, lamivudine, and lopinavir boosted, ritonavir boosted lopinavir. That is 200 of lopinavir and ritonavir 50 mg. 2 tablets twice daily. And if you have TL efavirenz, so we can go for TLE, or TLD is the ideal. If they are not available, we can go for TLD or TL. Next is children above 6 years of age and more than 20 kg. The drug or the regimen of choice are zirivudine plus lamivudine plus dolutegravir 50 mg, because it's above 20 kg and above 6 years, 1 tablet. The regimen would be given according to the weight band. But if there's anemia that is below 9 gram % of hemoglobin, we would go for abacavir, lamivudine, and dolutegravir as well. If the child is below 6 years and below 20 kg, according to the NACO guideline, it is zirivudine, lamivudine, and lopinavir, ritonavir. And if hemoglobin is below 9 gram %, if hemoglobin is below 9 gram %, we have to go for abacavir. The first dose, and remember, we have just received the less than 20 kg. we have just received the OM, and it was, if it's below 6 years and 20 kg, the OM was zerodin, lamivudine and lopinavir, because at that point of time 10 mg dolutegravir was not available. We just received the mail just now. So it is, and so regimen would change. Or the first regimen would be, let me repeat, this is a, just now we received an OM, the next slide. The preferred regimen in a child is, if it's a, is below 20 to 30 kg, it would be ALD, abacavir, lamivudine and dolutegravir 50 mg. And if it is child below 20 kg, the regimen would be abacavir, lamivudine and dolutegravir. Okay, we do not give LPVR. It is always abacavir, lamivudine and dolutegravir for children as well now. Okay, this mail came today and OM is dated 24th December for children. Next slide, please. Situation that require an expert opinion. If source HIV status is unknown, PEP is advised on case-to-case basis based on severity of exposure, epidemiologic likelihood of HIV transmission prevalent in that area, and high-risk activity of the source person. Remember, do not delay PEP initiation in a case of known or suspected pregnancy. Just because we assume the person to be pregnant, should we start PEP? Definitely, do not delay. Breastfeeding issues in the exposed person, source patient is on ART or possibly has HIV drug resistance, refer the consultant expert as soon as possible. Refer to an expert in case of drug intolerance, any major toxicity, non-adherence, complications, example, major psychosocial problem. Next slide, please. HB vaccination after an accidental exposure to blood. It is important to remember that the person exposed to the risk of transmission of HIV is also at risk for getting infection with HIV, HBV and HCV. HIV vaccination after an accidental exposure to blood. So HBV vaccination status of exposed person, never vaccinated. So action taken would be complete hepatitis B vaccination series has to be initiated. Vaccinated, anti-HBs not known, give hepatitis B vaccine booster. Vaccinated more than 5 years ago, give hepatitis B vaccine booster as well. Note, if hepatitis anti-HBs not known, testing for antibody level is not necessary. Hepatitis B vaccine should be given as soon as possible after the exposure. Do not wait for anti-HBs results if the test is done. Adequate levels of anti-HBs is above 10 international unit. No HIV vaccination is required in such cases. Next slide, please. Go back, please. And remember, there are no prophylaxis available against hepatitis C. So the only prophylaxis we know is universal safety precaution that would prevent all bloodborne pathogens. Next slide, please. Lab evaluation. Baseline lab investigations would include in persons taking PEP, it is the standard regimen, baseline HIV, HCV, anti-HBV, complete blood count, serum or serum transaminases, HIV, Hep B, Hep C of exposed staff within 6 days. Just because we do not have the baseline reports of the exposed person, we are not going to delay ART or PEP for that person. So we give them the PEP drug and ask the exposed person to get the baseline test immediately, especially within 6 days. Next, please. Follow-up of clinical and lab monitoring during PEP. So follow-up should be 7 days, 14 days, 28, 12 weeks after starting PEP. Monitor for acute seroconversion or primary HIV infection, which happens within 3 to 6 weeks of exposure. We know there might be fever, there might be rashes, lymph node enlargement, throat ache, etc. avoid blood donation, avoid breastfeeding, pregnancy. Go for safer sex practices. Rather, it's better that we don't go for sexual activity till 3 months. If you have to go for safer sex practices. Person should use universal safety precautions. Adherence and adverse drug reactions should be counseled, should be explained, and they would be told to come back to the ARTC center when such incidents happen. And on the timing and in person taking PEP, complete blood count, creatinine, fasting blood sugar or random, patients on DTG, second week and fourth week after starting PEP, and HIV test at 6 weeks, 3 months, and 6 months. Availability of PEP. PEP drugs are required on an urgent basis after accidental exposure and should be available and accessible round the clock. In all cases, the first dose of PEP should be offered as soon as possible. So do not delay PEP just because the person's baseline status is not there and the source person HIV status is not available. Don't do this. So start the PEP. We can jolly well stop it. No issue. We can always give loose drugs if necessary. It's always for the benefit of the healthcare providers to prevent an infection. PEP regimen should be made available from ARV drug stocks in the casualty, labor room, ICU, emergency, and in most places where you think it would be beneficial for the healthcare providers to access. Exposed person should go to the designated clinical officer. People should know whom to go, please. That is very, very important. For complete risk assessment should be done. HIV counseling and testing and PEP are essential. All hospital staff members must know whom to report for PEP. So for these things to happen, sensitization for HIV and PEP is very important. The health institution should conduct HIV sensitization program at regular interval of time at various departments. A regular check should be made for expired drugs for replacement. I've told you this. PEP cases should be documented in the registers as well as in the SOCH portals as well. Next slide, please. Post-exposure prophylaxis is the second best approach to occupational exposure. Why should non-exposure exposure as well? Why did we say the second best? That is what we have, right? But this is post-exposure. That is after the exposure, we are thinking about how to prevent. But what is the best approach? Let's go. Next slide, please. It's before the exposure happens. Go back, sir. It is the best is universal safety precaution. It is prevention is always better than cure. It is always prevention is better than cure. So best is prevention. Be calm, use your wisdom, prevention. That is the best approach. Second best is post-exposure prophylaxis. Let's go. Activities associated with needle stick or sharp object injuries. When does it occur most? During use. See, 52% happens during use. There was a study and it says during use of sharp and needle stick, you prick. So recapping of needles, orange, it is around 3%. So we're not supposed to go for recapping of needle, that is gone. Bending of needle, those are gone. So we have to know what is the universal safety precautions tells us. We should equip ourselves with latest guidelines and information. Next slide, please. What are the devices associated with percutaneous injuries by percentage of total percutaneous injuries reported? So, disposable syringe. So, it is a disposable syringe, agreed. But how do we dispose of? That is very important. Do we have a needle cutter, manual or electrical? Do we recap the needle? Do we bend the needles? So that can lead to exposure. See, it's around 24%. This is around 20. Suture needles. We think suture needle is a solid needle. We won't get a prick. Chances are less. No, see, it's around 26%. Look at the other things. So look at the other ways of transmission, other causes of percutaneous injury. So each and everybody contributes to an infection. So risk factor increases. So we have to know and prevent this kind of injuries or this kinds of scenario. Next slide, please. So prevention is the key. Prevention is always is the key. Prevention of to exposure to HIV is universal safety precaution. Universal safety precautions. Primary prevention is avoid occupational exposure to blood and other potentially infectious material. For me as a healthcare provider, for each one of the healthcare providers, any client coming to us, any patient coming to us, any duties we are performing, we would consider the person to be HIV or Hep B or Hep C positive until or otherwise this prove that they are negative. So consider them as potentially infectious. That is very, very important. And use of personal protective equipment is a must. And please don your protective equipment in a right sequence and get it off in a right sequence as well. And say no to recapping of needles, which is a capital no. Yes. Next slide, please. Standard precautions, and precautions is the key to step. This is the key and this is the game changer. Precaution, universal safety precaution is the game changer. If you do your work well in a proper way, chances of exposure would be less and you won't need PEP at all. Next slide, please. What I have come to the end of my slide. What are the key points? They are: make HIV transmission to the HCP as minimum as possible. So remember, to make it minimum, we have to think about, we have to talk about prevention, prevention, prevention. Next is implement universal work precaution plan in the facility and see to it that it is done. Consider all patients or sample as potentially infectious. PEP initiation as early as possible within 2 hours and definitely not later than 72 hours. But if they come delayed, we have to give them, but we would tell them, inform them about the efficacy of the PEP drugs. And definitely just because we do not have the HIV status of the source and the exposed person, we should not delay PEP. In such cases, we start. If necessary, we can stop it as well. Documentation is a must, very important. Why is it a must? Because that would tell us what are the ways people are getting exposed. That would tell the hospital or the health unit to consider more sensitization program in that phase, in that area. Sensitization of healthcare providers and accessibility of PEP should be there around the clock, even if the ARTC centers are closed. Person exposed to the risk of transmission is also at more risk of getting HIV along with Hep B and Hep C as well. Next, please. Thank you, all of you. Thank you for sort of bearing with me, listening to me, and wish all of you a very happy New Year. Have a wonderful life, wonderful days ahead in the new year. And thank you, Sweta ma'am and Praveen sir. Thank you, ITAC. And thank you, Mr. Lutfer, for helping me.
Thank you, sir.
And
Thank you
any
so much,
questions?
sir. Yeah, thank you so much, sir, for the wonderful session. Any from the participants, please feel free to put your questions in the chat box. You can also unmute and ask questions.
Good afternoon, sir.
Good afternoon, Dr.
Sir, I am Dr. Tripathi from Bhubaneswar ART Center, Odisha.
Good afternoon, sir. How are you?
I am fine, sir. How are you?
Fine, thank you, sir.
Presentation, sir.
Yes.
Sir, my question is, once I faced that situation, I just described that situation and what should have I done? Kindly advise. One day, one male person, he reported that he was actually doing MSM activity through some mobile app, and he was called by some person and he went to attend that person.
Right,
And
sir.
instead of that person, another person was hiding himself, and he suddenly came out and he forcefully did, I think, follow me.
I understood your question, sir.
And he came to me. In this case, what should be done actually?
Thank you for raising this question. NAPO till date does not give any PEP for sexual activity. No PEP should be dispensed for sexual activity apart from sexual assault, rape cases. Apart from that. But what we do is that we can always go for writing a proper prescription for that patient and ask him to get the PEP drugs from outside. NACO does not give PEP medicines. There are no OM. I have inquired. There are no OM for giving PEP drugs for sexual activity. We have to go for proper counseling, write a proper prescription, and explain it to the concerned person, and he or she or they should get the medicines from outside. But do write a proper prescription.
Sir, understood this. Sir, my question is actually in this case, will it be counted as rape?
That person would tell you. He should, because
he told that he was forcibly, he was made to do sex with him forcibly with another person with whom he was not interested. He was called by somebody else, but another person was hiding himself, and he suddenly came out and forcibly did sex with him, probably anal sex.
I understand, Dr. Tripathi. Absolutely wonderful question, sir. The thing is, this part of the question does not come under the purview of PEP. When a person has unsafe sex forcibly, it's a legal issue. There's other agencies, other departments who would deal with it. As doctors of healthcare institute, we would talk about PEP only. If there's a forcible interaction, forcible intimacy, the concerned person should inform the law agencies. We are not going to come in between, sir. Okay?
Sir, my question is, he was insisting for free PEP.
No, I understand. No, what you can do, sir, what I do at times, because this is not available in all the medicine shops. You came as a humanitarian person, give 2 or maximum 3 drugs, and tell the concerned person, these are the places you can go, or if you have numbers of any what do you call that, medical representative, or you can search in the net and give them the number or tell them the company's name, they can get the medicines. Okay?
Sir, why I am putting this question? Because
Yes.
there is one provision that if, in case of rape victims, they should get free PEP.
Absolutely. You're right, sir.
But in this case, is it coming in under that purview?
I understand, sir. You are absolutely correct, sir. But the thing, he would first, before talking about rape, he should lodge a complaint with the legal authorities, sir.
Sure.
Then it should come through proper channel. He would be checked. There should be proper clinical investigation. Everything would come into place, sir. Just giving PEP is not enough. If it's a legal issue, it should come through proper channels, sir.
That means I advise him to report to police, but absolutely. He was reluctant to go to police.
Absolutely, he should go. He should go, right, sir? You did it correct.
And if the patient does not go, in that case, what should he do? We should advise from outside to purchase outside. From outside.
I won't use the word purchase. I would say you get it from outside. We would detest from using the word purchase. You get it from outside, because there's no NACO OM which tells us to get to give medicine. You can give for 2 or 3 days maximum till the time he gets the medicine. And remember, when he goes out to get the medicines also, there's stigma attached to it, and stigma comes in 2 ways. There would be guilt, stigma from the person himself. I had sex outside. I had sex, and another thing is, what would people think about me? Self-stigma. So there will be a lot of inhibitions. So we have to go for proper counsel. And as doctors, I know doctors are wonderful counselors. Sir, you are very senior. I'm very sure you would counsel the patient or the client wonderfully, sir. Okay.
Sir, my question is another question.
Yes, sir.
Sir, in case of actually so many private institutions are there, private medical colleges are there, and private big hospitals, corporate hospitals are there, and they are not keeping PEP with them, and they are sending somebody exposed accidentally, some of their employees, they are sending to us to get free PEP. Is it correct? Actually, they are violating HIV Act also by this process. They are not. It is the duty of the employer actually, as per HIV Act, to keep PEP medicine, they can take technical advice from us. But the supply of, so far as supply of medicine is concerned, that should be done by the institution concerned.
Thank you for this question, for raising this topic. Because we have to, for any healthcare providers in working in any institute, whether private or government, we have to provide PEP according to OM. We cannot deny PEP. For whether the persons are not, whether the private institutions are not keeping PEP, whether it's correct or not, I think I'm not the right person to talk about this. Your respective staff, connect with your respective staff, inform them. That would be the right place to lodge any issues we want to share. And we cannot talk about such things. We can talk about the okay, sir. Thank you.
Okay, sir. Thank you very much.
Have a wonderful sir. Kemoti achanti, bhala achanti.
Sir, बहुत भला अच्छी sir.
Thank you,
Thank you for talking in Odia. Very
Okay.
pleasant. Your talk in the Odia is very pleasant, sir.
Thank you, sir. My pleasure, sir. God bless you.
Yes, sir. Thank you very much, sir.
Thank you, sir.
So there's one question in the chat box. Can a private doctor take PEP from ART center?
Okay. Who wrote this? Which from?
It's from Shukla Nimais.
Absolutely. A private doctor definitely can take PEP from government hospital. Definitely. We cannot deny PEP. We have to give PEP with right prescription. Only in case of sexual interaction, intimacy, we cannot give PEP. We have to write the PEP prescriptions, counseling, everything has to be done. For any occupational exposure, we have to give PEP, whether it's half government, half private, pura private, we have to give PEP. We cannot deny. Okay, we have to give.
Yeah, thank
Is
you.
there any other question?
Shukla sir is a counselor from MKCJ Barhampur. Thank you, sir.
Thank you, sir.
Yeah. Any more questions? Please feel free to put your questions in the chat box, or you can also unmute and ask questions. So I don't think there are any more questions. Thank you so much for the wonderful session. Thank you to all the participants for patient listening. Wishing you all a very happy new year in advance. Thank you. We'll conclude the session now.
Thank you, ma'am.
Thank you, sir.